3 sessions into trauma work, a client is doing everything right, showing up, naming the memory, rating the distress on cue, and still something in the room won't settle. Their shoulders stay up around the ears, their eyes keep checking the door. Here's the question that opens this whole episode. What if that bracing is not a sign the work is stalling? What if it's the most important clinical data that you will get all day? So welcome to Target Memory. Today's episode is called Racial Trauma is Not Just Another Target, and it's drawn from a larger series that is going to be on this channel covering the latest research and dialogue and evidence regarding culturally responsive trauma treatment and how an anti-racist framework for EMDR and brain spotting is currently evolving. And good news, because I know all of you who are busy and took time out today to give this a listen will be able to earn continuing education credit for listening today. It's through our partnership with the Pinnacle app. And so this episode is continuing education eligible. Everything you need is in the show notes and how to access continuing ed credits, and I will link it below. So quick boundaries first. This is psychoeducation for licensed and pre-licensed clinicians. It is not therapy, not case consultation, not EMDR basic training, not a credential, and use what fits your training and your state's scope of practice rules. Set aside what does not, because we must practice within our scope and competence. So by the end, you will be able to do 3 things. 1, name at least 3 ways that racial trauma differs from a single incident memory and case conceptualization. 2, describe how a culturally responsive anti-racist lens sharpens assessment, preparation, and target selection inside the 8-phase AIP EMDR treatment model. And 3, summarize accurately and with its limits what the current evidence says about EMDR therapy and race-related distress. And let me say this plainly up front because I mean it. This is not a critique of EMDR. EMDR is one of the most robustly supported trauma treatments we have. Everything today's episode is about using EMDR at its full potency. Its full power, so to speak, because here is our North Star. Racial trauma is not just another target, and seeing the whole context is exactly what lets the protocol do its best work. All right, let's go. Why racial trauma behaves differently. Let's get precise about what we mean by racial trauma, because precision is where the clinical power lives. In the literature, Robert Carter's 2007 framework calls this race-based traumatic stress. And he makes a distinction that's easy to miss, and it's clinically huge. He frames the response to a painful, sudden, uncontrollable racial encounter as an emotional injury, not necessarily a disorder. The symptoms can overlap with PTSD. Intrusion, avoidance, hypervigilance, but the injury model says the person is not broken. They've been hurt. Well, hold on to that because it changes how you sit with a client. And it rarely shows up as one event. It comes in flavors: direct, being profiled, demeaned, or shut out; vicarious, watching it happen to your community, or the same footage looping on your feed; historical and intergenerational, so harm that predates the client and still shapes what their family taught them to expect; and anticipatory, a nervous system that preloads for harm because experience taught it that harm is patterned and random. Now connect that to EMDR's engine, the Adaptive Information Processing Model, or AIP. AIP says symptoms come from memories that got stored in a maladaptive, state-dependent way, frozen with the original emotions, beliefs, and body sensations. And that reprocessing links those memories into adaptive networks. Beautiful model. Here's the nuance racial trauma adds. When the memory is actually 1,000 small encounters plus an inherited blueprint, plus a threat that is still active in the client's daily life, that's a richer network than a single index event. Same engine, bigger map. So let me make it concrete. And to be clear, this is a fictional composite, not a real client. So let's call her Maya. She comes in with hypervigilance after being followed through a store by security. A skilled EMDR clinician already knows to ask about the touchstone. And the touchstone is the earlier memory the present incident is wired to. And here's where culturally responsive EMDR shines. That touchstone search opens onto being watched at work, a teacher's assumptions years back, family warnings about staying careful. The vigilance is not a distortion to be corrected. It's pattern recognition, and now you can see the whole network you get to help her process. So the history-taking question expands. Not only what happened, but also what keeps happening. What did you inherit? What are you required to monitor that other people never have to think about? Honor that context, and the protocol does its best work. The body keeps the receipts, allostatic load. Okay, let's talk physiology, because this is where clinical rigor earns its keep. There's a concept called allostatic load, the cumulative biological cost of adapting to chronic stress over and over. Allostasis is how the body maintains stability through change. The load is the wear and tear when those stress systems stay switched on too long. When the recurring stressor is racism, the system keeps paying a small tax and the receipts pile up. In the room, that load can present as exhaustion, sleep disruption, vigilance, irritability, shutdown, chronic muscle tension, headaches, GI distress, shame, or a hard-won difficulty trusting new people, including you. Educators and clinicians like David Archer have done important work bringing this anti-racist, body-aware lens directly into EMDR practice. Here's the clinically rigorous move, and notice it's a move that makes your assessment more accurate, not less faithful to EMDR. When you ask about racism, you can correctly attribute these signals. You can see hypervigilance as an adaptive response to a real pattern rather than mislabeling it. And this lines up right with Carter's injury model. The work is not to convince a client that a world that has not always been safe is now perfectly safe. EMDR does not ask you to install a lie. EMDR asks you to help the brain reprocess what happened so the past stops hijacking the present while you stay honest about what is still going on and is ongoing. That distinction, past danger versus present, active danger, is one of the most important assessment calls that you will make in this work, and we will come back to it. So pause and consider. With your own caseload, where might you be reading a chronic stress adaptation as a symptom to be reduced when it's actually information about the client's environment? When you ask the question, the client's anger can become clarifying. Their caution can be understood and more intelligible. Their mistrust can also be understood as earned, a reasonable read of accumulated evidence. And naming that out loud, gently, often does something the protocol alone can't. It builds the therapeutic alliance that makes every later phase land. So Mark Nickerson's edited clinical work on culturally based trauma and EMDR pushes our case conceptualization to be more sophisticated, to hold the individual and the systems they live inside. This matters most precisely because EMDR is powerful and can move fast. When a tool is this strong, the conceptualization underneath it has to be equally strong. So let's talk craft, the skillful moves that make culturally responsive EMDR the high fidelity EMDR that is talked about and raved about. Okay, target selection. So EMDR already teaches us to find the right touchstone and the cluster it belongs to. So the touchstone is the originating memory. Culturally responsive practice widens that search to include race-related touchstones. The client may not volunteer unless asked. So the network you process is complete and the client feels seen. The negative and positive cognition. Here's a place where doing EMDR well and doing it culturally are the same thing. So Shapiro's model already insists the positive cognition can be ecologically valid, true and believable in the client's actual world. So when a client's world includes ongoing racism, an ecologically valid positive cognition is not, I'm completely safe everywhere. It's something like, I can read a situation and protect myself, or my worth does not depend on their bias. That's not bending EMDR. That's EMDR's own standard, applied with cultural precision. And you're careful that the negative cognition names the injury, not a self-blaming belief that quietly hands the client responsibility for someone else's racism. Preparation and resourcing. Phase 2. Resource development and installation is the most effective when the resources are the client's own. Instead of assuming a generic, calm, safe place works for everyone, you ask, what actually steadies you? For one client, it's a grandmother's kitchen. For another, an ancestral story, a faith practice, a community, a piece of music. Culturally congruent resources hold better under processing. Cognitive interweaves. When processing blocks, EMDR gives us the interweave, a brief, well-timed offering to get things moving again. A culturally attuned interweave is simply a more accurate one. It does not accidentally minimize the reality of racism to make the memory resolve. So none of this is a departure from fidelity to the model. It is fidelity to the model and to the person in front of you. Twofold. Use the protocol, then widen the lens. Same powerful engine, a map that matches the territory. Who's in the training room? So quick pivot, because culturally responsive care for clients depends on a culturally responsive profession. Lisa Hayes' training work intentionally centers BIPOC, Latin, Asian, and other clinicians of color who've been underrepresented in advanced trauma spaces. The premise is upstream. It's not only about adapting treatment for clients, it's about who gets access to the training. It's about who gets access to feeling safe in the room, whose clinical examples are treated as the default, and who gets consultation that actually understands racialized clinical burden. This is clinically relevant, not just nice to say, because the clinician's nervous system is in the room too. Clinicians of color may carry extra layers, vicarious trauma, racial battle fatigue, the labor of code switching, professional isolation, or being the only person willing to name what others step around. That affects capacity, presence, and the energy available for the hardest cases. And white clinicians carry real responsibility here as well, to do their own work, seek consultation, tolerate discomfort, repair ruptures, and not outsource their education onto BIPOC clients or colleagues. For us, making a continuing education episode, the takeaway is concrete. Technique is not enough on its own. Sustainable, culturally responsive EMDR rests on access, on the culture of training, on the quality of your consultation, and on whether identity safety is genuinely built into how we learn. So the better question is not, do I know enough to be done? It's what consultation, community, and accountability keep me practicing with humility. That is not a one-time box to check. That is the job. So what the evidence actually says, race-specific work. Okay, evidence, data, reliable and validated. And I'm going to be careful here because careful is both ethical and what keeps us out of trouble with marketing regulations issued by the state board, our respective state boards. In fact, here in California, the Board of Behavioral Sciences tightened in April of 2026 the regulations around marketing of psychotherapy. So direct race-specific research is still emerging. Let's neither discuss it nor oversell it. The most recent piece worth knowing is Hung, Chan, Solosky, and Linville, 2025, in the Journal of Marital and Family Therapy. And here I want to be clinically precise about what they studied, the flash technique. Now, important accuracy note, and please hear this clearly, the flash technique is its own distinct standalone intervention. It is not EMDR. It was developed by Dr. Philip Manfield here in Berkeley, California, who is a longtime EMDR approved trainer with EMDRIA. And yes, the flash technique grew out of the EMDR world. It was originally used to help reduce a memory's intensity before EMDR processing. But the peer-reviewed literature now recognizes flash as a separate standalone technique. So when we say flash, we are not saying the 8-phase EMDR protocol, a different tool, related family. The published study uses the phrase EMDR flash technique in its title, and I want to be transparent about that. But the technique itself is properly understood as distinct. So with that straight, the study tested a self-administered flash protocol delivered over telehealth to reduce distress tied to racial trauma memories. 39 participants, 3 sessions of bilateral stimulation, distress tracked on the SUDS scale across 5 time points. The result was a statistically significant within-group drop in distress with a large effect size in their numbers, an ETA squared around 0.31. Encouraging? Genuinely. It points at something that matters. Racial trauma often shows up where access to care is hardest, so a brief, low-barrier telehealth-friendly tool is worth studying. But let's hold it with both hands. A small sample. Single group, pre to post, no control condition. So we can't rule out other explanations. Self-reported distress only, and self-administered, not a clinician delivering a full protocol. So a promising signal that invites bigger controlled studies, not a finished verdict, and definitely not a marketing claim that anything cures anything. For historical grounding, there's also Rittenhouse 2000, a case report of EMDR with a biracial client experiencing complex PTSD, where discrimination was central to the clinical material. One case cannot establish efficacy, but it's an early, honest example of race-related material being treated as clinical material. So here's the most we can responsibly say, and I'd put it on a slide if we had one. There is emerging race-specific evidence that EMDR-based and flash technique-based approaches may reduce distress linked to racial trauma memories. There are clinical case descriptions of the work, and separately, there's a strong evidence base for EMDR and PTSD treatment overall. All right, so the broader EMDR evidence base, and that broader base is where the ground is firmest, so let's give EMDR its due. De Jong, De Roos, and L. Lethy published a 2023 State of the Science review in the Journal of Traumatic Stress, describing EMDR therapy as an evidence-based treatment for PTSD, supported by more than 30 published randomized controlled trials in adults and children, with most international clinical guidelines recommending it as a first-line treatment for PTSD. That's not a fringe intervention. That's one of the best supported trauma therapies we have. Wilson and colleagues in 2018 in Frontiers in Psychology, a systematic narrative review, concluded EMDR improves PTSD and related symptoms and has been applied across a range of cultural contexts, while explicitly calling for more research in diverse populations. Read that carefully. Applied across cultural contexts does not mean culture is irrelevant. It means that the model travels, and we still need to study how language, social location, and systemic oppression shape delivery and outcome. And Akaturk and colleagues, 2016, in Psychological Medicine, a randomized controlled trial found EMDR reduced PTSD and depression symptoms among Syrian refugees. Not a race-specific study, but directly relevant to culturally responsive trauma care, because that trauma is bound up with displacement, loss, and systemic conditions, not just a single private event. So the implication is steady, and I'd argue pro-EMDR all the way down. Validated EMDR protocols can be delivered in culturally grounded ways when we explicitly attend to context, safety, identity, and ongoing oppression. We keep the 8 phases, we keep the AIP model, we keep targets, cognitions, bilateral stimulation, SUDS, and validity of cognition, or VOC tracking. We just ask sharper questions while we do it, and the work gets better. All right, so takeaways you can use today, next Monday. Let's make it usable. 5 takeaways. 1, assess the full range of racial stressors. Don't stop at, have you experienced trauma within your scope and at a tolerable pace? Ask about racism, discrimination, microaggressions, community violence, historical and intergenerational trauma, migration stress, and ongoing threat. You're building a complete target network. 2, name racism rather than over-pathologize the person. Carter's injury model again. If a client is responding to racism, the issue is not that they're too sensitive. They were hurt. Naming it builds alliance and sharpens your formulation. 3, prioritize resourcing, preparation, and pacing when threat is ongoing. This is the past versus present call. Processing a danger that hasn't ended is a different task than processing one that's over. Strong phase 2 work, culturally congruent resources, stabilization, clarity about current safety, sets up everything downstream. 4, think in time, recent incident, touchstone, future template. So racial trauma links a present day moment back to school, to a family warning, to a medical dismissal, to an earlier encounter. And the future template matters. Rehearsing the client stepping into a coming situation with more voice, more choice, more protection. 5, integrate identity, community, and cultural strength. So for many clients, healing is not only private symptom relief, it can be reconnecting with language, family, faith, chosen family, art, or ancestral resilience, and your EMDR resourcing can be built around exactly those. Bottom line, culturally responsive EMDR is not a new protocol, and it isn't a correction to EMDR. It's EMDR practice at its full power, faithful to the evidence base and the client's lived reality at the same time. Which brings us home to the title. Racial trauma is not just another target. It's a doorway into identity, history, survival, body memory, systemic harm, community resilience, and the ethics of how we practice. So here's your one-line refrain to carry out the door. Honor the whole context, and the protocol does its most powerful work. EMDR therapy has a strong first-line evidence base for PTSD. The race-specific work, including the flash technique research we discussed, remembering that the flash is its own distinct method developed by Dr. Philip Manfield, is emerging and promising, and we hold it honestly, limits and all. The invitation is never to abandon evidence-based treatment. It's to practice it with more context, more humility, and more precision. So to claim your continuing education credit for listening to this episode, head to the show notes. You will find the link to the Pinnacle app and how to get your credit. And if this episode resonated, this is part of a larger 5 series that goes deeper into racial, historical, and intergenerational trauma, culturally responsive EMDR, and brain spotting, integrated case formulation, clinician positionality, rupture and repair, ethics, and accountability. So again, thank you for listening and for taking seriously the work of treating trauma without erasing the conditions that created it. So We'll see you in the next episode.